the side effect that we all know should be burned into their brains, the pneumonitis.
Let's talk about in DB09 what we saw, and Dr. Macklin, I'll turn to you for this. Walk us through a little bit what you anticipate in terms of adverse effects related to trastuzumab deruxtecan, the combination of T-DXd with pertuzumab, and any pearls that you may have for managing some of those toxicities.
Sure, and so I'll just start by saying that, reassuringly, we didn't see any new safety signals from frontline T-DXd. As expected, we already have, much experience with the drug since 2019. The way that I talk about this with patients is we need to talk about the side effects that we can expect that are more common and very manageable, and then we need to talk about the side effect that we all know should be burned into their brains as to when they need to call us in the middle of the night, right? The pneumonitis. So the more common day-to-day side effects I find can be very manageable. Fatigue and nausea are the two main ones that, at least in my clinic, I experience with patients. And for fatigue, I talk to my patients about lifestyle modifications. Exercise has been tested in the metastatic setting to combat chemo-associated fatigue. For nausea, we've learned over the years that this is a pretty emetogenic regimen. So being aggressive with pre-meds up front and then offering drugs like olanzapine at bedtime can be really helpful for managing the nausea. And, dose reduction can be very effective. Some patients their right dose is a dose level down from the standard, and that can be a major change, a game changer for the patient. For the pneumonitis, we know that roughly 10 to 12% of patients will develop any level of pneumonitis. Fortunately, most of that is low grade, but it's really, having that conversation with your patient. If you get short of breath, dry cough, fever, that's not a wait until the next infusion kind of discussion. That's I need to know right now kind of discussion, and instituting proper measures.
Absolutely, well said. So being proactive. Yeah. Dr. Javeri, are you using the 4-drug or 3-drug antiemetic prophylaxis? What is your approach to managing nausea?
Absolutely. It's been a game changer, actually. Trying to ensure that we use the 3-drug regimen, and on top of that can offer olanzapine as the 4th drug, has really, really helped manage nausea in clinic, which I agree is the most frequent toxicity that we face actually with T-DXd. And while we worry about ILD pneumonitis, thankfully it's a little lower, but of course the vigilance has to be higher given what it could do in terms of outcomes, including fatal outcomes that can happen. But I think nausea management is really, really critical because that's your day-to-day toxicity, and it's a modifiable or a preventable or a toxicity that you could provide supportive care for. So I think making sure that our patients are taking it and making sure that they're reporting it back to us so we can do something about it. Fatigue is a very interesting toxicity, and I completely agree that, you can see that with T-DXd as well. But I also feel like we as doctors, as our clinical care teams, need to probably probe into the fatigue a little bit more, which we don't necessarily do a good job at necessarily all the time. But it is subjective in some patients, right? And we need to get a sense of what is the level of fatigue that they're referring to. Is it really impacting their activities of daily living? Is it something that they're facing, but they're able to continue to do their, daily livings? And that can have an impact on how we want to modify the dose for a given patient in clinic. So that is something that I think we can do a better job at assessing this otherwise subjective toxicity.